is phocomelia? What is amelia? When mothers who were pregnant use this thalidomide, the children born had no limbs or 1 or 2 limbs here and there left. Right? So why this happened? What is it called as? What is it called? It is teratogenicity. Didn't they know it when we were making this drug? The scientist who was under this drug research, he didn't know about this. But a group of people in the laboratory, they knew that there is the toxin which is entering in the bloodstream of the child. Medical school was strongly telling placental barrier is the best. No chemicals will enter. And you have a school of science telling that chemicals can enter anywhere. They can cross the blood-brain barrier, they can cross the placental barrier. So this was not interchanged. Because of this reason, 2 million babies were born like this. Now you understood? There is an importance of publication. One doctor would have told, they would have written, somebody will be looking at it and say, blockbuster warning, pregnant ladies, don't take it. That didn't happen, right? Why? Because different strains are working in a different way. They didn't mix together. Intercollaborative publications were not there. There was no discussions even. So this made these many babies lose their life or disabled life, gain a disabled life. So this was an issue because they were not publishing, correct? So this is all about it. And now this drug, thalidomide, is entering in India. Do you know? Thalidomide was banned. They have put it on the bar. It is sleeping in the shelf. But latest, people understood that thalidomide is a magic drug but should not be given in pregnancy. With the warning telling that not in pregnancy, you can go for anti-angiogenesis property, and now thalidomide is being repurposed for cancer because of its very novel properties where the other anti-cancer drugs are not having. Are we missing a drug because of a wrong propaganda? What is it understood through this? Thalidomide caused amelia, phocomelia when used in pregnancy. Thalidomide can carry anti-angiogenesis property, can be an excellent anti-cancer agent. So this was missing in this publication. Understood? So when you are publishing, how careful you should be. You can't just give a generalized statement and whatever you think, you should not do that. You have to deeply analyze. That is the thing called as discussion. In the discussion, you properly analyze and write, and at last you will write, this is my finding. This has to be substantiated by further findings. When you close it, you will close it. When you are closing your manuscript. Correct? So this is a beautiful mechanism of therapeutic action of thalidomide, which was sitting in the shelf years and years and years together. And this is now going to help the research community for anti-cancer properties. Next, heart attack, what is the drug immediately you give? Triple drug therapy. Life-saving, do you know? If you are not listening for furthermore, it is okay, at least this 3 you have to listen to. If somebody is getting a heart attack, what ought to be given? Triple drug therapy. First aid for heart attack? No? Aspirin, 325 milligram. Clopidogrel, 150 milligram. Atorvastatin, 80 milligram. For this, how many tablets should be given? 3 tablets? 5 tablets? 8 tablets? What is the usual dose of atorvastatin? Check it. How many? This much you have to give all together. Because 75 milligram aspirin will be there. You have to have 325 milligram. How many? 150 also will be there. So 150 and means 2.5 tablets of that. Like that you have to put a bunch of tablets so that platelet aggregation will be prevented and you can have a life-saving activity. Who told this first? Initially aspirin was not for heart attack. What was it used for? Analgesic. Analgesic, yes. This man, Dr. Lawrence, in 1914, when he was doing tonsillectomy, tonsil surgery for the patients, he gave analgesic aspirin. Then he saw people are bleeding. That is one observation. Second, he found such people are not getting heart attack at all. So it is so nice, no? He was having a very longitudinal study. Our problem with the studies are cross-sectional. pharmd do for 6 months, pharmd does for 10 months, and you leave it. That is very much cross-sectional. This person had a very longitudinal study and observed that people who had aspirin, they had prolonged bleeding. People who had aspirin, they are not getting heart attack when compared to people who were not given aspirin. Such a wonderful finding, it is life-saving. Till now, 1914 he has identified. He has written to many journals and people just rejected it. They say, you know, what are you speaking? Aspirin is an analgesic. How can it protect you from heart attack? Not at all possible, right? Recently when I was talking to my medical college dean, she was telling, why do you give garlic? Garlic for lipidemia, hyperlipidemia. So I told it has some properties. Can you remove the active constituent and try in the animals? And for that you have to have tons and tons of garlic. Then I went and studied what is garlic doing. Can you give any guess? Garlic against lipidemia or garlic against heart attack? People do say garlic is good. Garlic is good. Against heart attack, why? Not because of its anti-hyperlipidemic activity, but it is because of its anti-inflammatory activity. Garlics will have anti-inflammatory activity. Inflammation is also a culprit, basically, which will cause a lot of block in the blood vessels. And there is a sudden death. Now you are correlating. Aspirin was an analgesic anti-inflammatory. Even your garlic is analgesic anti-inflammatory. Because of anti-inflammatory property, heart attacks are stopped. So I know few BPharm students are here. If you have anti-inflammatory drugs repurposed for heart attacks, how good it will be? Because the other drugs are all very expensive. Cardiac drugs are very expensive, cancer drugs are very expensive. But cancer is having an element of inflammation. Heart attacks are having an inflammation. Stroke attack also has an element of inflammation. So you can have group projects. You have a BPharm group project. Pick as much as possible anti-inflammatory drugs and work on the targets of heart attack or stroke or cancer and see if you have a good docking score and go for it. If you have in vitro setting or in silico setting, you can give it run. Okay, so coming back to this man identified it. Many a times he has published, people rejected, and one point finally when he was no more, people identified, yes, this can cause platelet inhibition, this can prevent the platelet aggregation, and so it can be a prophylaxis or treatment for heart attack. And till now the world is using it. 1914 he identified, we are in 2023. We are still using it. So it is a magic drug because of this observation. This much is being told why medical professionals are not writing. We are writing, we are not writing, you keep aside. Medical professionals, doctors are not involved in writing much. Nurses are not involved in writing much. Why? Because they could not organize it. You give them tons of night duties, they will do. You give them any other work, they will do. The moment you say publish, because I am also from a medical college, I am closely associated with the medical college. The moment you say publications, they say, why do we have to? It's okay. They are not ready to do it, they are lazy to do it because they don't organize it, basically one. Second, their expectations are too high. They say, I want to get it published in New England Journal of Medicine and it is not even fit for a normal medical journal. So this is the problem. Where you have a problem is, your expectation is high and we are not organized. So every one of us in this stage also will feel that we need a good publication but we don't know how to write it. Correct? So let us go and see how to write. So this is where we will get regret. Anytime you write to a journal office, we will get regret. How many times? Any number of times. I have around 80-90 publications and I am reaching an impact factor of 100, but still I will have rejection in my test mode. 3 times rejection, 5 times rejections, 10 times rejection, but still we will work on it. So we have to have a lot of patience. Now getting into the types of manuscripts. You know what are the different types of manuscripts? Heard about it? Articles, you know, journal articles. What are the types, you know? Yes? No? Full length paper. It will be 5,000, 6,000, 8,000 words. Then you have something called as case reports. Heard about it? Case reports, case series, review articles. Heard about all these things. Okay. Full length paper is a structured format. You will have everything into it from introduction, methodology, very well elaborated. Then you have something called as brief reports or case reports. Brief reports and case reports, you will concise everything together. And case reports basically they tell about one single case. Case series will tell about some 4 or 5 of similar case. Okay. So I give you one example. There was a surgical site infection. You know what is SSI? Surgical site infection. Heard about it? After surgery, if the prophylactic antibiotic is not good and the patient is getting a surgical site infection, so the prophylaxis is not good. Understood? You give a prophylactic antibiotic, then go for a surgery, and after surgery, if there is a surgical site infection, your prophylaxis is not having a proper coverage. So that is a barrier. So what we found was, we found some 14 to 15 cases of surgical site injury after cefpodoxin as prophylaxis. You know cefpodoxin is a cephalosporin? Cephalosporin was given, 1 week it was given, after that abdominal surgery was there, surgical site infections were there. 14 cases after this, we identified the hospital stay was very long. There was re-surgery done to those patients and extra burden of drugs given to them. So this was the scenario. We then found that cefpodoxin is not indicated in the guidelines. Understood? It was not a prophylactic antibiotic. Conveniently it was given. Doctors have chosen that for any convenience, I don't know, because it was not a proper prophylactic guideline. So there was SSI. If I have to write one case about it, it is case report. If I am writing 14 cases on it, it will be a case series. Understood? Why do you have to do it again? I will tell in my setting this has happened. I have not followed the guideline. There is a medication error as well. But when you are doing also, be careful that this is not giving you a coverage. Should I have to tell that? You need not mention your hospital, that is okay. But knowledge sharing is required. I can put it as an abstract, go to the conference and present. I can make it as a table, stick on to the nursing station. I can call all the doctors and tell this is not a prophylaxis. This much I can do to make people understand that please don't give this. Alright? So that is about the case report and case series. Then is about the review. Have you done your review? Review? Small review? Narrative review? No. So for no. Review is basically a narrative review. I say my convenience. I will see how many other articles are there on something and put together and say this is that. For example, lung cancer can be treated by this herbal. This herb will work or not, I don't know. So that is my research question. So I will take this herb is the key term and then I have the lung cancer put together. I will study how many studies are telling about it. How many studies at your convenience? There are 100, 200 studies existing. You take only 10 and tell that this is good. Or you take only 15 and tell this is not good. So you can tell whatever you want, which is not very systematic. It is your wish. Okay, so always the narrative review has less respect than systematic review. Narrative reviews have to be very intense, then it is okay. Otherwise, your convenient writing narrative reviews will not have really good impact. Next comes systematic review. Systematic review is something where you have a proper search terminology. So what was my question, research question? This herb is going to prevent lung cancer. So about this herb, since inception, since 2000, since 1990, whatever publication limitations were there, all those things I will take. Okay, if it is doing it or not. Okay, so I have around 1 lakh literature. So can I sample it randomly? Systematic review will not allow it. So you have to check every title, every abstract and see it is inside or outside. You call it garbage in, garbage out. You put all the garbage in with all the keywords and then just segregate what you want. So you will narrow down. Finally you have set of articles. In that set of articles you will see the quality check. That is called as critical appraisal. Do you have a journal club? You have a journal club? So will you appraise the articles there? You will take an article and say how they have done, where are the mistakes, what are the limitations, what are the gaps. You do it, right? When you do it, you will develop your skill of appraising an article. So here you do a proper critical appraisal with few checklists. I will show you the checklist. So with all those things, then you find few articles are supporting, few articles are opposing. Then you go for something called as a meta-analysis where you have the statistics being applied and they say these many studies are supported with a big sample size. This many studies are opposed with a small sample size. With the sample size, with heterogeneity and so many other parameters, the meta-analysis will finally give you, yes, this herb can work against lung cancer. No, this herb is not working against lung cancer. This is how you end up with a systematic review. Now, are you having a difference between the systematic review and the normal literature review or narrative review? You found the difference? Are you able to appreciate it? Yes? No? Alright. So, systematic review and meta-analysis, they are going to form the highest level of evidence there. So, SR stands there. Then you have all the other studies under it. So, when you are interested in publishing of high value, systematic review would be something good. But it is not a normal task. Maybe 1 or 2 years intensively you have to work to get one paper published. It's very tough, but you will be given highmost respect in the scientific community. So this is what I told you. You have few checklists based on it. Have you studied about consort? Consort diagrams? Heard about it? In systematic review you need consort or you follow Prisma. So different study designs will have different guidelines. For observation you have SPRODE. Alright, so this all are required basically for understanding the guidance. Okay, let us get into the manuscript writing, especially how do you frame a title. What all should be there in the title? What all should be there in the title? All these things. Okay, I say you, this is a study about the stroke and sleep incidence. How is the sleep and what is the risk of stroke? And this was a 10-year study. It was a follow-up study. So can you tell me what all should be there in the title? Yes? That green shirt? Next.
It is an interaction study. Please respond.
Green shirt?
No, sure.
I like green. Please tell me how can we have the title over it? You can sit, it's okay. Give me a title for this. It is a sleep study. It is, no, it's okay, you can sit. It's a sleep study. It is correlating sleep with stroke. It is a 10-year-old study and it is a follow-up study. Now you tell me a title for this. Next is the other green. Straight opposite. Girl green. Yes? Come on. No, he has to tell. If he is not, then it will go there. Give me a title for this. I'll pull everybody. Quick. No lunch otherwise. So get connected. It goes this way. Habitual sleep patterns and risk for stroke and coronary heart disease. So everything is put in. It is not very lengthy. Alright? And this is a 10-year study. It is a follow-up study. Your title should be this much crisp. It should put every element in it and people have to understand by this. But now you don't know there is a correlation or not. You see, you just gave a statement telling that this and this was compared for 10 years. That is one type of writing a title. Also you have other types. Theme based is what I have told you first. Theme based means study designs. Have you heard about study designs? Cohort, case control, randomized control, all those things. So that is the theme based. Question based is there. Will this herb be working for that? Question mark. That can also be there. Then you have something called as finding based. Aspirin can work against prevention of heart attack. That is a finding. You have just declined it. So which style you will use for different manuscripts? The first style you goes for, the theme based will go for journals. For a journal when you are writing, you write a theme based. What is the theme based? You will tell what is the study, what is the follow up, what is the study design, everything you will put together, make it crisp. So that is for the articles. Second thing, question based can be anywhere in a book chapter or an article or short communication. It is like, inducing the curiosity of a reader. And when you go for abstracts, conference abstracts, they will send hundreds of conference abstracts. That time you can go for a straightforward thing. This is working against this. This is not working against it. So that the reviewers will not sit and think what is the answer for it. You can just one line, you can write the answer for it. So basically different articles will have different style of writing, even the title page. Then is about the author, being told about the authorship and losing an author, missing an author, not giving credits to the authors, whoever all involved in it has to be put. I am your friend, can you give my name? I have just given you tea, coffee, Horlicks while you are doing the manuscript. Anyhow, I have contributed. No. In acknowledgement? Acknowledgement? No word for that, please. Yes, you can give. He's so generous. Provided tea, coffee will not give it. Substantially, you have to contribute. Contribute in sense, I have given a space for you and made you to do a research in that area. You can give an acknowledgement. Thank you for Pharmacological Modeling and Simulation Center, which is my center. Many researchers come, work and go. So they don't give my name. Instead, they will tell PMSC. Salutes for you. Right? When I have sat with you to design something, my intellect was put into it. I was designing project for you. But I didn't do anything. But I did everything. Then, whom am I? Where should I be placed? Which author? That is my dream. I made you to do. What am I? Corresponding author. I will be the last author and I will be the corresponding author. You did all the work. You did laborious work, this and that and everything, compiling, collating, statistics, everywhere you did. You will be the first author. For you doing this, few people would have helped. While writing, somebody will check it, cross-check it. They will help you in editing. They will give you some suggestions. Those all will be the middle. Understood? What is authorship? Authorship, first author who really worked for it. The last author whose intellect was put in it and who framed everything. And middle authors who had contributed. Because one person cannot write it, cannot make it so huge. So this is how you have to give contributions. If you like somebody, if you want to impress somebody, that is not the authorship doing it. Right? So we have to be genuine and publication ethics is there. That is one part. Second, when you put my name, without my consent, I can again accuse you. You know that? That is very dangerous. More likely to get into problem or trouble if someone is putting the other's name without consent. So when you are writing my name, you have to take consent from me. That is one. Second, putting my name, it is good. I have 100 publication, 101 publication I get. But if your article is substandard, if it is getting retracted, have you studied about retraction of article? Journal office will take it back, telling that the quality is not good. If it is retracted, all my publication will be analyzed back. And there is a threat for my other publication also to get retracted. And it is a scientific, misconduct or very bad thing for a black mark sort of it for a researcher having the publications getting retracted. Understood? It is a very big issue. So somebody is putting your name, don't give your name please. Unless otherwise you know this is a good one or not. I will never dare to do it. Because it is my name. I put in some publication which is substandard, and somewhere my other publications also will get affected. Don't be greedy about publishing. If you don't publish, beautiful. Publish properly. Understood? If you can carry that message, it is done. How to do publication, how you learn it, how you make it, that is different. How you should not, you should know first. Okay? Lot of ethics clearance, concentration is required. Then you put authorship also. Then don't fight for it again. You have to be clear when you are doing it. Who is which author? First only we will write. That's okay. I'm good, right? Able to hear? Traditional teachers. Okay. So title is done. Authors are done. Abstract. What is abstract? I find my students writing abstract for 500 words. Abstract is just abstract. What all should be there in the abstract? Types of abstracts. Structured, unstructured. You can put everything in a paragraph, that is okay. Or you have the background, the method, or in the background you will finish your objectives also. Method, results, discussion, conclusion. That is structured abstract. So here you will see the background weekly you have to tell the national significance and objective. How much are you having space to fill this background? How many lines you can write the background? How many? 3, 4 lines. Within 4 lines, 3 or 4 points, quickly you have to tell what is your background. What is my background? I say aspirin has anti-thrombotic activity. What is my background? People die of heart attack. You have to prevent it. So, I am trying if aspirin can prevent it. Over. That much is your background. Make it little more scientific and beautiful. It is very blunt, very raw, but that is the thing what you have to put for background. Next is my study design. What is my study design? I will take people who all come with this and I will give and see whether it is working or not. So what is this? If it is a cross-sectional, I will put cross-sectional. If it is observational, I will put observational. On how many patients? 100 patients I did it. So these are quickly to be written, telling that this is a cross-sectional study design with 100 participants enrolled, this many males, this many females, and the minimal age, the age group was this much. So on this patients I have done it. If you have you should have first of all inclusion and exclusion criteria, you have to put that criteria also. Then comes the results. In the results you put how many patients were there, what were their demographics, and how many got the intervention, how many were better with the intervention, how many did not get better with the intervention. Alright, so that is over. 1 or 2 lines quickly you will write about the conclusion telling that aspirin at 325 milligram acted as an excellent antiplatelet agent preventing heart attack, while 75 milligram did not give anything. Is it clear? What did I tell to the scientific community now? Aspirin is good. If I tell that, I am not completing it. Aspirin is beautiful, you can give. What should I give? How many times I have to give? When should I give? I have not given anything. Aspirin is good. That is not to be given. In the conclusion, when you are finishing it, properly you say, in a given sample, aspirin 325 milligram behaved as an excellent prophylactic against heart attack, acute myocardial infarction, while 75 did not. Or you say, only with 325 I have tried. Further doses have to be studied. Are you clear now? You are not giving a straightforward statement telling that this is yes. You say, in my study population it is working. Further studies have to be evaluated because my 100 population, 100 samples will not represent the entire world. Asian population, South Indian population, that to Karnataka population. I will make it that. Now be clear, when you have an abstract to write, this much you have to know. Don't eat the brains of the teachers please. Make it proper, crisp, and then go with it. Alright? So this is how it should be. Quickly you see 3 or 4 lines. Endovascular therapy is increasing. Okay, so this is about plasminogen activator. You know what is plasminogen activator? Tissue plasminogen activator. Name a drug? Yes, correct. Okay, before you get the loading. Come on, I am expecting one correct answer. Altiplace. Where do you give this? In stroke, ischemic stroke. When should you give it? When should you give it? Is this question important? Stroke, ischemic stroke, population defined. What is the intervention? Altiplace. Why this? When should I give? Why should I ask? Tell me when should I give? Sometimes you tell no. 1 hour, 2 hour, 3 hour, 5 hours. Tell me immediately. When should I give? 180 minutes. There is a stroke occurrence, and within 180 minutes I have to do. What is 180 minutes? How many hours? 3 hours. Why not 3.5 hours or 4 hours or 5 hours? Why? No? What is plasminogen? Plasminogen will dissolve the clot. Which clot? Fresh clot. Okay, you have two processes here. In the coagulation cascade, you have all your coagulation things there, and then you have the fresh fibrin, which is converted to soluble, insoluble. Those cascades are all there. It will become, the clot will become very solid after 3 hours. The clot is fresh and dissoluble when it is within 3 hours. Tissue plasminogen activator will dissolve the clot. Okay, when you give it in 3 hours. When you give after 3 hours, it will break the clot. If it is breaking the clot is strong. It can go anywhere, block the end artery and kill the area. When you give tissue plasminogen activator, Altiplace, which is 0.9 milligram per kilogram, 180 minutes before, it is helping the patients with ischemic stroke from further damaging. Ischemic penumbra is protected. If you give it after 4 hours or 5 hours, this is going to cause secondary stroke. Yes. So, this much has to be there in CRISP when you are discussing or when you are concluding. Understood how clear you are? Correct? Yes. So, this is one study based on that, and it is telling we have independent clinical trial. Out of this many patients, giving this by 3 hours is beautiful. After that, it is not good. So that clarity should be there when you are crafting an answer. So let us go to the introduction. So abstract is done. What all should be there in the abstract? What are the big manuscript has? In concise, mini or mini manuscript is your abstract, and there you have time to put it everything first. And the same way you have to talk also. When you are asked something, when you are going for an interview, you will not be given time for long time to talk. 30 seconds. Will you be able to deliver what you want? 20 seconds, 10 seconds. If you can tell just the keyword, it is over. So, I used to go to my associate dean or the hospital in charge. So, he gives me 30 seconds to tell about the global cancer consortium or about antimicrobial stewardship program. I just stand like this and tell, sir, time dependent, concentration dependent. 2 types of antibiotics are there. That is not given properly. So, let us go into that and look at it. Then he will ask, what is time dependent? Then that too, 20 seconds I have to tell. Time dependent antibiotic, you know what it is? Penicillin is time dependent. When you are giving penicillin, you have to give for a long time. Infusion. 6 hourly we say penicillin, piptas. The piperacillin, you go for the hospital rounds, right? Piptas is being given. How is it given? What is the dose? 4.5 grams, beautiful. How many hours? 6 hourly, beautiful. How long there should be infusion? There is where the point. 4 hours infusion should be given. Okay, so they give for 30 minutes. When they give for 30 minutes, there is no time dependent concentration there. The antibiotic is not working. When you find it to be resistant, go for meropenem, go for imipenem, and induce resistance for the whole globe. What is the problem here? This is the problem. So I was given 30 seconds to explain that. Then he looked at me. Okay, what is it? Okay, fine. Go get me the guidelines. Up to date is not telling it. Micromedics is not telling it. We have gone for many other studies and finally found yes. 4 hours infusion if you give. 4.5 grams for 6 hours. Every 6 hours. For 4 hours continuous infusion when you give, the antibiotic resistance is not there. Antibiotic is properly working. This is what being expected from you. You have to have everything on hand. When somebody is giving an opportunity, close it. Just give the keywords. So So your abstract should be like that. Understood? Introduction is a discussion with somebody like me. I would love to listen to me. So now you come and sit, give your story, I am ready to listen. So that is your introduction, but still the introduction should be only 10% of the main manuscript. If you have 100 words for the manuscript, 10 words should be for the introduction. 100 words for the introduction. Alright? So introduction will give a little more space for you to tell what is the problem, what is the gap identified, and what are you intending to do. While you are doing that, you have to also show it is not only me, many people were looking for this gap fixing. You say, I am looking for this, that is okay. You also have to show even this researcher, that researcher, this researcher also looked for it. But when they looked for it, this was the gap. They did a study, but this was the gap. So I want to fill the gap. And it is very beautiful, fantastic if you find a guideline for it. American Guideline of Psychiatric Association is looking for it and they didn't get it. And I am trying for a solution. It looks so mean, that's okay. But you can say that. This is all happening. In your introduction should be like that. But our introductions, when I see, it is filled in pages and pages and pages without any stuff in it. Alright? So you have to have, why is it required? Manuscript writing, why is it required? Is it required? It is. What for? For promotion, for completing your PhD, for getting a job in scientific writing. It is important. Okay. If it is important, where all it is important, you have to define it. When I write about manuscript on manuscript writing, I will write it. The students have to understand this. Why? Where is the gap? You see, Indian publications are substandard, not to the level of the global thing. Whoever is taking it, they say the appraisal is not fine. So that I have to teach my students about manuscript writing, and that is very important. So that is where you have to show something like that. So here you say, does someone other than you think that this question is important? For you, this question is important. You have to also show the others are also interested in it. Then people will have interest to read your subject. So this is how you have to do introduction. Common errors in introduction. It is too long, 3 pages, 5 pages, you can't even read. It should be 1.5 page, ideally to see. Lack of coherence. Coherence is connectivity, consistency, those all will not be there. First paragraph and the second paragraph, it is not matching at all. So that way it should not be. You have to link between paragraphs. People have to understand why they're reading it. Focus on many different questions. So when you have a research question, your thesis or PhD may be big, but with whole PhD you will not write one paper. You have to subclassify it. Based on small findings, you will make one thing. So if you have so many rationale, it is confusing. You will not be able to end the paper. You say, I will have a big paper, it won't work. You make it proper. Big paper or small paper, you have to make it more organized here. So here I will tell you something, number of references. Some teachers would tell you put more references. If you put more references, then they will think you have extensive literature review. Heard it? If there are 100 references, people will feel that extensive review. If there are 100 references, then why are you doing this research? 100 people have done already, no? Isn't it? So references has to be there, but how much is it required? That many should be there. Unwantedly quoting things. And 1997, 1800 AD, those all should not be quoted. Get it very new as much as possible. 2023, 2021, such references should be there. Then you have predatory journals and good journals. So that I think you will get it in the afternoon class. So don't take it from the predatory journals. You at least quote from good journals. So those are all basically required when you are quoting the references. Then we used to write like this. Can we look into what is wrong here? Kim, Brage, when analyzing the prevalence of anterior frostbite in 1897 children with complete primary dentition, detected that during the period of primary dentition, the factors of the incidence of this type of mole occlusion were 43.6 genetic and 56.4 postnatal. This sentence is telling about the Kim grade. Kim the Great case of that. No, not required. Keep it as simple as possible. Very smart writing is that. Not pages together. In a paragraph, if you can do it, it's beautiful. Right? So you have to remove unwanted clutters and increasing the page number or the size of the manuscript. That's not going to fetch you anything. Even the same way when you are writing exams also. They say 60 pages I write, I will get out of it. No. Teachers are smarter than you. We will look only for the keywords. So guidelines, be concise as much as possible. Thumb rule is only 10%. Count your words. 10% of your manuscript should be your introduction, ideally. Pay special attention to the text coherence and cohesion. There should be consistency. Do not present long review of literature. It is boring. Your literature has to have that. Avoid sentences which is telling about the author of the article. The author who was the German scientist, he identified, not at all required. What he identified? Sometimes name, sometimes number. We will put in numberings, right? Name also is not required much. Alright, so shall we break for the lunch? Sorry, we have just check it out. Continue to learn about manuscript writing? Little better now, no? Yeah. Sir made you get scared. Now I am pacifying you then. Right? Thank you. Thank you for the patient listening.
Thank you. Let us take a very small lunch break. Last time itself I have said it's a tea break for you people, but it has a lunch break. So let it short. So your lunch time is going to get shorter now. So please come back within 30 minutes because afternoon session, if you remember, sir said the process, how we are going to have today's session. Sir said that he will be introducing some rules to us also, right? If you want to learn, we have to spend some time, right? So you have to cut short some breaks today.
Your first will start by 6:30 evening.
They came from Bangalore just to interact with us and to explain the things to us. So we have to give our part. Okay? So within 30 minutes, we'll back to our sessions. Okay? Enjoy the lunch. Be back by 2:10.
Mark 210. Asim.